The 2026 Dyslipidemia guidelines changed the clinical focus from point-in-time risk calculation to measuring cumulative atherogenic exposure. Atherosclerosis is mathematically an area under the curve problem. LDL-C drives plaque, and exposure duration is just as critical as concentration. Comparing lipid control starting at age 20 versus 50, late intervention leaves a massive, unchangeable block of accumulated exposure. This cumulative exposure model dictates a new mandate for primordial prevention, requiring aggressive health behavior counseling as early as childhood to prevent dyslipidemia from developing. For young adults between ages 18 and 39, the guidelines provide specific triggers for initiating pharmacotherapy: an LDL-C of 160 milligrams per deciliter or higher, or a strong family history of premature atherosclerotic cardiovascular disease, or ASCVD. ASCVD is a broad term for conditions caused by plaque buildup in the arteries, such as heart attacks and strokes. Preventing cardiovascular events in a patient's 60s requires capping their atherogenic exposure in their 20s. To accurately assess risk in adults aged 30 to 79, the 2026 guidelines permanently retire the older pooled cohort equations, or PCE. PCE refers to the equations previously used to predict a person's 10-year risk of a first heart attack or stroke. These equations relied on outdated birth cohorts that systematically overestimated cardiovascular risk in modern populations. The new standard is the Prevent ASCVD equations. Using contemporary data, these equations result in risk estimates 40 to 50% lower than the older PCE. Consequently, the guidelines establish a 3% 10-year event rate as the new threshold for net clinical benefit. This crosswalk translates the old PCE logic to the new Prevent reality. A 5% risk on the older PCE is now roughly equivalent to a 3% risk on Prevent. To navigate these lower numbers, the guidelines introduce a clinical workflow called the CPR framework. CPR stands for Calculate, Personalize, and Reclassify. It is a 3-step process designed to refine a patient's risk profile beyond simple equations. This mathematical reset ensures precision. The numbers are lower, but the clinical intent to capture and treat hidden risk is sharper. The Calculate step establishes the new prevent-based baseline for primary prevention, starting with the updated definition for borderline risk. On Panel A, borderline risk is 3 to under 5%. Here, preventing an ASCVD event outweighs causing diabetes. Panel B defines intermediate risk as 5 to under 10%, where clinicians must definitively initiate statin therapy. The 2026 guidelines also reinstate absolute lipid targets, which now operate alongside standard percentage reduction goals. For patients in the borderline and intermediate risk categories, the absolute goals are an LDL-C under 100 milligrams per deciliter and a non-HDL-C under 130 milligrams per deciliter. These targets must be met while concurrently achieving a 30 to 49% reduction for moderate intensity therapy, or a 50% or greater reduction for high-intensity therapy. Lowering the intervention threshold to 3, an LPA level of 125 nanomoles per liter, or 50 milligrams per deciliter, acts as a 1.4 times risk multiplier for ASCVD. A level of 250 nanomoles per liter or higher is a severe risk enhancer, doubling the patient's baseline cardiovascular risk. The next tool is Apolipoprotein B, or ApoB. ApoB is a protein found on all potentially plaque-forming particles and provides a more accurate measure of total concentration than LDL-C alone. Specific triggers for ordering ApoB include patients with diabetes, those with triglycerides over 200 milligrams per deciliter, or when LDL-C targets are reached but residual risk is suspected. Standard lipid panels often camouflage high concentrations of dense particles, making Lp(a) and ApoB mandatory tools for true personalization. Also within the personalize step are high-risk phenotypes. These represent patient populations where the prevent calculator is bypassed entirely. Adults aged 40 to 75 with diabetes, chronic kidney disease stage 3 or 4, or HIV, require immediate lipid-lowering therapy, regardless of their baseline LDL-C or prevent score. There is a clinical caveat for the geriatric population. For patients over age 75, automatic initiation is paused in favor of shared decision-making based on overall health span. If a clinician and patient are undecided about starting therapy at borderline or intermediate risk, they move to the reclassify step of the CPR algorithm. The ultimate tiebreaker is coronary artery calcium, or CAC scoring. CAC scoring is a specialized CT scan that measures the amount of calcified in the heart's arteries to break clinical deadlocks. Clinicians must factor in both the absolute CAC score and the patient's standardized percentile against their specific demographic to make a final treatment decision. Bypassing the calculator for high-risk phenotypes and deploying CAC for ambiguous ones ensures treatment is driven by actual biological disease rather than statistical probability. We now shift our focus to the aggressive new clinical mandates for secondary prevention in patients living with established ASCVD. As shown in this flowchart, the very high-risk category now explicitly includes ASCVD patients with concurrent chronic kidney disease, or CKD. CKD refers to a long-term condition where the kidneys do not work as well as they should. The immediate required intervention for this group is starting a high-intensity or maximally tolerated statin. The uncompromising new hard targets for very high-risk patients are an LDL-C under 55 mg per deciliter and a non-HDL-C under 85 mg per deciliter. If the sub-55 target is missed, the algorithm traces a sequence of additional therapies, including ezetimibe, PCSK9 monoclonal antibodies, inclisiran, and bempedoic acid. While ASCVD patients not at very high risk have a target of under 70, in practice, the vast majority of secondary prevention patients will trigger the sub-55 threshold. These aggressive targets reflect a clinical reality. Standard lipid levels are often insufficient to stop events from recurring in established disease. This leaves the challenge of managing isolated or persistently elevated triglycerides, which are fats in the blood that can contribute to artery narrowing. Even with high triglycerides, statins remain the primary, most effective therapy for reducing overall cardiovascular risk. The clinical pivot occurs only when triglycerides reach extreme elevations of 1,000 mg per deciliter or higher. At this threshold, the immediate medical objective shifts to acute pancreatitis prevention, which justifies the use of specific triglyceride-lowering agents. The 2026 guidelines provide a toolkit that is mathematically precise through PREVENT, biochemically nuanced via ApoB and LPAA, and biologically aggressive with sub-55 targets. Applying the CPR framework and these stringent thresholds allows clinicians to directly suppress a patient's lifetime risk of cardiovascular disease.